So, welcome to the 1760 sessions where I sit down with founders building something against the grain. I'm Harry from 1760, and today I'm joined by Dr. Jaron Stout, founder and CEO of Collaborative Pharmacy Consulting. Jaron is a consultant pharmacist who looked at a corner of healthcare that had worked the same way for 40 odd years, decided it was broken, and then rebuilt it. He took a service that nursing homes tolerated as, a paperwork burden and turned it into clinical care they actually want. And he is now on a mission to open that path up to the whole profession. Jaron, thank you so much for being here.
Yes, it's great to be here. Thank you very much. I appreciate it.
Fantastic. So I just wanted to kick off with, you spent your early years as a consultant pharmacist inside this old model that we speak of. When did you first realize it was broken? And can you talk a little bit to that old model so our listeners can know what needed changing?
Absolutely. So I'll kind of explain, like you said, like what kind of opened my eyes, and it'll kind of explain the broken aspect, at least the most important aspect, one of the more important aspects to me. So when I first started in 2012, I worked for a pharmacy, and so a consultant pharmacist is a very niche area of the pharmacist industry and profession. Because CMS, the Centers for Medicaid and Medicare Services, require that every skilled nursing facility employs a consultant pharmacist. And that pharmacist has to review every resident's medications once per month to make sure everything is safe and appropriate. And I help meet that requirement. Historically, what happens is the nursing homes reach out to a pharmacy because they need drugs for their residents. And then at the end of the negotiations to have those drugs provided, they're like, oh, and by the way, we need a consultant. Can you just send one of your guys over here once a month? And that's a terrible way to do it. There's an inherent conflict of interest. In fact, just to explain how things started for me, when I started in 2012, it was for a pharmacy called Senior Care Pharmacy. And I had been working there probably 3 or 4 months. And my boss was with me in the pharmacy one day, not at one of the nursing homes. We were in the pharmacy, and the director of the pharmacy was there, and we were all just, having some lunch or something, or just chatting. And my boss, who was the director of the clinical services, the consulting services, he said something like, oh, it makes me excited when I get rid of these unnecessary drugs. And the director of pharmacy just turned and looked at me like, you realize that hurts our bottom line, right? And that was the day, that was the first chink in the armor for me as a professional in that setting. And it kind of bothered me. And the longer I went in my career, the more I realized that there were independent consultants out there, and that they had more freedom in how they approach their consulting duties. The next chink in the armor was I was about 6 months in, because the pharmacy, hired me part-time to see how good I would do. And if I did well, they would expand me into a full-time position. And it was looking that way. I was getting good feedback, good rapport. I had great relationships with all the clients. And one day I went to one of my nursing homes, and the director of nursing there, she looked disappointed when I walked in the building, even though we were great friends. And I was like, oh, I'm sorry. I thought you looked forward to my visits. And she's like, Jaron, we love you here, but we know you're just going to give us a giant stack of paperwork. And that was the day that the trajectory for my career changed. I recognized that, there's an inherent conflict of interest if I try to get rid of unnecessary drugs. And B, I realized that these directors of nursing don't see any value in what I'm doing, because all I'm doing is regurgitating data from drugs.com. I mean, not literally, but at the end of the day, anybody can go to drugs.com, type in a regimen, and identify potential concerns. And that's all we were doing. And I realized that I have training that allows me to assess the data that comes out of drugs.com and tell you what is relevant, what is not relevant, rather than just passing the buck and telling the physician and the nurses any potential problems that they should research. It should be me doing the research and identifying what is relevant to this specific patient and what is not, and having dialogue with them about it rather than putting in a report that they need to monitor for bleeding. So that was the first step.
Yeah,
Um,
huge.
and that's kind of what started the journey for me. So
Yeah,
I don't,
okay.
I don't know if that answers your question.
Oh,
I tend to
100% does. I love how the penny dropped early on around the bottom line being affected, for
right.
then for you to turn around and be like, hey, do you not enjoy my visits? For then for you to probably realize this whole model needs changing. And what is the impact that you feel you've made so far by changing this model?
So um, I think, after about 5 years of working for that pharmacy, I reach out to my boss, and ironically, this boss he's my best friend. Like, we've known each other 20 years. We worked together as pharmacy
Nice.
technicians. We went to pharmacy school, different pharmacy schools, but graduated the same year. Uh, he hired me as a consultant. Then, later down the road, he worked for me at my company. But so when I was there, I reached out to him and I said, "Hey, have have you ever thought about using collaborative practice agreements to kind of streamline the process? Because this goes back to what that nurse said to me. Well, you're just going to give me a giant stack of paperwork. I wanted to make it so that we don't give them
Yeah.
work. We give them a list of stuff that we just fixed for them while we were there. And a collaborative practice agreement is when the physician, unfortunately, this varies by state and how they
Yeah.
manage these laws surrounding collaborative practice agreements. But it's when a physician delegates their ability to write a prescription or write orders, and they delegate it to a pharmacist. So it means I can walk in and operate on behalf of that physician and actually
Yeah.
fix the medication problems rather than, give them a laundry list of potential problems that they should review.
And the one
Um,
thing that jumps to
yeah.
my mind, sorry to jump in straight
No,
away,
you're good.
is you're known in the industry in your particular area. What would it be like for someone starting new? Because I suppose there has to be a huge element of trust involved, because they probably know Dr. Jaron, he knows his stuff. We want to work with collaborative. But what's it like for someone potentially new coming into the market because they don't have that level of trust?
Very good question. It is a very much a relationship based business.
Yeah.
So, um, coming in fresh, like, you have to kind of earn that respect. And I think that's one of the issues I ran into with collaborative practice agreements. Because yeah, you're right. I have that great rapport, great trust, great relationships. But when I started hiring people, that complicated things. Like, I had to spend time kind of giving them, context of what to look for. Because if we're going to go in and fix these problems, we shouldn't just do it willy nilly. We have to have good protocols in place to
Yeah.
identify if it's appropriate to move forward with these changes, and have good relationships with these physicians. So those are things that take time, and that's why I've learned. Anytime I work with a new physician, or if I'm bringing a new pharmacist to work with a physician I've always known, spend a few months running everything through them, discussing everything you find through them. And then you get an idea of what they want you to do without talking to them. You'll get an idea of things that,
Yeah.
hey, I've never discussed this with this physician, so I'll go talk to him about this. But they'll also give you insight. Oh, well, if we want to make that change, let's make sure that, this, and this is in place already, or that we've tried this, this, and this. So
Okay. So
great question, because that is an aspect of it.
yeah, of course. But like if they're under your umbrella, I suppose there's already the element of trust there. And then how much time then goes into, training these pharmacists to work for you? Because I suppose you can't be everywhere at once.
Yeah, yeah, and that's been one of the toughest lessons for me to learn is, I spent the first 5 years just doing it all on my own.
Wow.
2018 is really the year that I that's when I started doing my own company full time, and having to rely on other people and trust them was hard for me. But it was a learning experience, and having that, the ability to have a team around me has been monumentally
I can
changing
imagine.
and helpful. So industry standard, eh, for most consultant pharmacists, the consensus is that it takes about 6 months generally for a new consultant pharmacist to hit their stride.
Okay.
Um, there's a lot of moving parts because it's a heavily regulated area of healthcare. Uh, you're dealing with a situation where The facility has OTC drugs in stock in the facility, but then they have an outsourced pharmacy, an outsourced physician, an outsourced physical therapist, in-house nursing.
Yeah.
Everything that is provided in a nursing facility is a vendor service. And there's so many moving parts that it can be very complicated to really understand until you have been there a few months and you see how it all fits together.
Yeah.
So,
I wonder how many people last past the few months when they realize how much is involved.
yeah.
So, earlier in your career, you told me before when we spoke, like, you got laid off, and then 2 years later, you're running your own firm, and that's an amazing pivot to hear about. What did that forced push teach you, essentially?
Well, so ironically, what so I mentioned earlier how I was talking about doing a collaborative practice agreement, and my
Yeah.
boss, I talked to him before, and we were about to do it. He gave me the green light, and he said, "Don't tell corporate. We're going to tell them after we show that there's a benefit."
Nice.
A month later, that company sold uh, to a very, very large pharmacy, and they wanted nothing to do with what I was trying to do. So it
Yeah.
got kind of put on the back burner. However, like you said, there was a need for it, and I had already talked to a bunch of people about it. So that was actually where my company was started. Was while I was working for this other large pharmacy, and it was just a very small part-time thing, just kind of tinkering with that idea of a collaborative practice agreement. And it started to catch on, and about a year later, it was starting to get big enough for me to quit. Like I couldn't manage both of them at the same
Wow.
time. And then 2 weeks later I was laid off. So I'm
Okay.
I'm very fortunate
So
that
I must. We didn't dive into the weeds far enough at all.
yeah, yeah,
But that's an even better story. That it was
yeah,
almost, it forced your hand to do what you wanted to do anyway.
yeah, yeah. And so I think that, sorry for the confusion. I think the 2-year
All
component
right.
is because that's 2 years after I started the company is when I came up with additional concepts to add on to the collaborative practice agreement. Um, Stuff that I'd been researching for a while, because there are pharmacists doing a lot of innovative things across the country in different settings. Most of it is in outpatient ambulatory care, working in physician practices, doing very innovative things. And it took me a while to figure out if that was a feasible business model that I could implement in nursing homes,
Yeah.
because there's a lot of different regulations surrounding that. But once I pieced it together and I spoke with a healthcare attorney, that's when it started to explode. It was about 2 years later. So
Okay. Awesome. And I think we spoke about last time as well. Medicare billing. Once you cracked the Medicare billing through physician supervision, you said it pretty much caught fire. So what actually changed on the ground?
yeah, I think when nursing facilities are getting additional services and they don't have to pay extra for it, it's a huge bonus.
Okay.
Because we're now getting additional revenue streams from the actual medical director because we're performing services on their behalf rather than charging the nursing facility for these additional services. So, when we show up and we say, "Hey, we're gonna help your physician, and we're gonna get rid of all your, well, not all of them, but we'll take your 25 residents who use sliding scale insulin," meaning you have one nurse who has 25 residents that they have to poke 4 times a day to check their glucose levels in their blood and identify if they need an insulin shot on top of it. So that is a massive time burden for the nursing facility. So, you know, coming in and saying, "Hey, I'm going to work with your physician. We're going to cut your 25 residents down to 4 so that you only have 4 people to check 4 times a day, or what, and we'll even cut it down to twice a day so they don't have to do that many." It's a huge waste of time to check somebody's glucose. And we've known this for decades.
Yeah.
Sliding scale is not a great way to manage and day-to-day maintenance of blood glucose for diabetes. So once we, cracked that code, using billable services through the medical director, these nursing facilities were recognizing how much benefit they could get out of it. And then we added, these nursing homes are heavily, heavily regulated around how they use psychotropic medications to make sure they're not just using these medications to sedate and restrain people. And so once we started to add on additional behavioral health services and do it in a manner that meets the facility needs and the patient need, that's very difficult to do. And so that has been our biggest area of growth, is just those
Yeah,
aspects.
I love it. And remember, we spoke about, the old way was one consultant covering 15 to 20 homes once a month. You want one consultant in 5 to 7 homes once a week as part of the medical team. Why does that shift matter for the patients themselves?
Absolutely. So, you know, like I mentioned with you, the traditional role is we undercharged for our services from the get-go, and that's why pharmacies were offering it. They didn't care about consulting; they cared about the dispensing contract. That's where they made their money. So they were undercharging illegally for these consulting services. And so what happens is, because they undercharged, they had to load up one consultant pharmacist with like 15 homes, maybe even 20 in some situations, just to break even to cover that pharmacist's salary. And so that's the traditional model. Just load them up with 12 to 1,500 chart reviews every month and go to 15 to 20 homes. That's terrible. So with these additional revenue streams, I wanted to make it so that one consultant pharmacist, instead of 15 to 20 homes once a month, they go to 3 to 5 or 6 homes once a week. And that is almost like a medical director. They
Yeah,
can't be 20 homes. They had to go to 3 or 4 or 5, and they show up at least once a week. And they have mid-levels that show up every day, or not mid-levels. They don't like that term. But nurse practitioners and physician assistants that will cover that day-to-day task every day. And that's kind of the direction I wanted to take it. And that's where we're headed with these additional services. But I will say that as lofty as that goal is, and it's what I want, it might be harder to accomplish because now AI is on the horizon, and I
yeah.
might just break even. uh, we might, add on all these services and then automate everything so that, we tack on more homes again. So
Yeah, of
that
course.
is the goal I want to reach, but hopefully we don't over automate it. So
Yeah, of course, because you still need that personal touch in there. And like, look,
exactly.
we speak
Yes.
about being part of the medical team. There's so much to that. It's the relationship, which is so key. What do you feel that the part of being part of the medical team let a pharmacist do that the old drop-in model never could? Really?
Great question. So, you know, it's a new perspective, and it is a perspective that we need more in healthcare. And I'm not here to lobby for provider status. Pharmacists don't need provider status to make the impact that we're capable of making. In fact, my healthcare attorney that I've known for years, that I work with, her name is Lee Davidian, and she has contacts within CMS, the regulating body of healthcare for our government. And they, in her discussions with them, they're like, why are you trying to get incident to levels, or regulations more favorable for pharmacists? Look at all these billable mechanisms we've created that pharmacists could do, and yet none of them are doing anything, like chronic care management, behavioral health integration, uh, all these different mechanisms that could be done with a pharmacist, and hardly anybody's doing it. So why do you care for these regulations? And in a way, CMS has built a pathway for us to follow to become providers. And we have professional organizations that have done nothing about that. They have not promoted this. They don't even they hardly educate anybody
Yeah.
on it, because it's outside of the realm of being stuck in the box of a pharmacy selling product, which they can never get their brains out of, providing a product. So, to answer your question, I'm trying to remember what the question was. I'm kind of
I said, like, what does it mean to be part of the medical team? What do you
okay. Yeah.
against the old drop-in
So,
model?
because of that perspective change, that's
Yeah.
where the benefit is. So every physician, every nurse practitioner, every physician assistant they'll have very similar training in how they approach patient care. And a pharmacist approach is dramatically different from their approach, and it's very simple.
Two different roles.
It's
Yeah.
synergistic, and it complements what they do. So the two of them combined is fantastic in my experience. So just as an example, a great physician friend of mine, I saw a progress note from him. He was talking about a resident, and he said, okay, patient has a history of stroke. So let's maintain their aspirin 81 milligrams daily. Done. He moved on, overlooking the fact that the patient was on 2 antiplatelet drugs, aspirin and Plavix. So because of the fact that he was following his training, he didn't do anything wrong. He was following his training. He was going down the list. He saw aspirin, boom, moved on.
Yeah.
For a pharmacist, physician's going to start with the resident. They're going to go down to their conditions and then connect that to their drugs. The pharmacist is going to start with the drugs first and match that with their conditions. So for the pharmacists, they're going to go aspirin, and Plavix. Oh, okay. Why are we on both? Because if you're going to be on both, it's usually a short-term duration.
Okay.
When I found the progress note, it said history of stroke. I couldn't find any other conditions. A stroke means you use both of those agents for 21 days, and then you narrow it down to aspirin alone most of the time. So this resident had been on aspirin and Plavix for over a year. High risk of bleed, totally unnecessary, no benefit of having them together for over that year, and we were able to narrow it down. And I might add, 66%, and this is documented in the skilled nursing regulations by CMS.
Yeah.
66% of medication-related adverse events are preventable, which proves my point that the current system of consultant pharmacists in nursing homes is completely missing its mark. In fact, just to give you more context of what a typical consultant pharmacist would do when they see aspirin and Plavix, they wouldn't dig to find if it was appropriate. They would just send a note to the nursing facility saying, we need a monitor for bleeding.
Okay.
Overlooking the fact that all nurses are already monitoring every resident for bleeding, whether I identify a risk of bleeding or not. Every day they're going to monitor them and say no signs of bleeding due to bruising, no blood in the urine, no blood in the stools. They'll do that for everybody. They don't need me to tell them that there's additional risk. They're already monitoring it. So it's up to us to identify if it's appropriate. That's our training. It's not to just pass the buck to every other healthcare provider.
It's literally what I'm learning from this call is just how important the level of expertise on drugs that the pharmacist consultant is basically. And feels like from what you're saying, it's been underutilized for years. And there's a real gap that we can skip here because it's helping both sides of the fence, really.
Exactly, yeah.
And speaking of pharmacists, I'd love to talk about the Innovative Pharmacist Alliance, the IPA, and just so everyone knows it's not a type of alcoholic drink. So can you tell me about the IPA, what it is and the gap it fills for pharmacists?
Yeah, absolutely. So I kind of mentioned earlier that none of the current pharmacist professional organizations really do anything to meet the current need of pharmacists who want to do something innovative and different that isn't in a pharmacy selling products, right? They have such a difficult time in our professional organizations getting outside of that way of thinking. It's always centered around a product, strictly around a product. In fact, that was the problem with the consulting. They used the consulting service to say, oh, I'm going to have our consultant for our pharmacy show up there and switch everyone on levothyroxine to a different levothyroxine product called Synthroid, because we get a better margin of profit from that product than we do from the basic levothyroxine. So that is historically what they have done, and that has totally missed the mark because once again, they centered that consulting service around providing a product rather than a service.
Okay.
And that is oh man, that drives me bonkers. Like, why have we missed the mark for so long? So we wanted to make a home for innovative pharmacists across the country. Because if you go on LinkedIn, you see a lot of pharmacists doing a lot of very innovative things in different settings, and we're all doing it in silos. We're not communicating, we're not helping each other. There are pharmacists out there who want to do these innovative things, but they don't know how. And in order to figure it out, first of all, you have to graduate from pharmacy school, which is going to put you 6 figures in debt.
Yeah.
And then if you decide, oh, I want to do this innovative stuff, how do I do it? My pharmacy school never taught me this. Now I have to pay another pharmacist another 5 figures a couple times over or more to figure out how to do these billable mechanisms that I never learned in pharmacy school, and how to market it, and how to get into a physician practice. So we wanted to make a home, and we've been lucky enough to have ASCP see that there's a potential need and benefit from providing a home for us to do this. And ASCP is the American Society of Consultant Pharmacists. They were obviously the most natural place to put this in, but we wanted a home where we could bring in innovative pharmacists from across the country, break down these silos. Don't give up your intellectual property, but our profession is going to remain stagnant if we don't offer additional resources, input, insight, education on how to build these innovative practice models, especially with AI on the horizon. Like, look, there's a lot of opinions on this, but we are totally replaceable as pharmacists if we're not doing our clinical duties. If we're just double checking that a tablet is the correct tablet, that's automation.
You said it before. You can do the job from drugs.com if you want to do the bare minimum. You need to be leaning into the skills that you've gained over a period of time to actually deliver value, which is irreplaceable.
Exactly. Assessing and providing clinical insight and interpretation is where we are valuable. It is not looking at a tablet and saying, yep, correct tablet, and moving on.
Yeah.
So we need this home, and we need pharmacists to have access to these types of resources and break down these. And the more I talk to these pharmacists, the more I'm like, wow, like that's something I'd never considered before. And we're all doing very similar things in very different ways and not communicating, and all remaining stagnant as a result. And the more we break down those silos and work together and have a bigger voice, the more likely we are to be successful. So we're kind of building that right now with my colleagues, Courtney Myers and Thea Blystone, and the attorney Lee Davidian, who's been a huge component. She's been affiliated with ASCP in the past and present. She's been a huge advocate for pharmacists for the past 30 years plus. So it's been a great start to it to begin with, and we're excited with the opportunities.
So it's going to make the knowledge readily available. It's going to be inexpensive, so you don't have to keep paying on top to get yourself further in debt, and to work with specific pharmacy schools. So what really does success done right look like to you then?
When we have more pharmacists who are not... So pharmacists right now are experiencing burnout, mostly because there's a lot of discontent with the current status quo. You graduate with these clinical expertise and this knowledge, and then you go and look at tablets all day. And there's a lot of pharmacists who want to do non-traditional things. There's a lot. And so the more we get pharmacists working in physician practices, the more times in my setting that I have a physician walking into a building and saying, hey, let me provide your consultant pharmacist. The more I see that, the more I see pharmacists working in new practice settings side by side with physicians. That's, to me, a huge success. And I want to overhaul the consulting industry for nursing homes in general. And I want a bigger picture. I don't want to just work in nursing homes doing consulting. I want to make it into primary care. I want to do specialty providers. And that's, to me, that's the success I'm looking for.
Okay, amazing. And I can't wait to see this change and see as you grow. You actually told me that you're growing faster than you can handle at the moment. What does that actually look like and feel like on a Monday morning then?
Mondays are the worst. Um, right now it's uh my biggest frustration is just I have not had the capital needed to just one of the issues is, there's usually a delay in payment. If you're working in a physician practice, they have to submit the claim, they have to wait for payment to come in. Uh, that's an issue for another day. But also nursing facilities historically are very slow to pay. Um, I will say I'm very fortunate because I feel like my services have been valued highly enough that I have not seen a huge lag in payment. I would say I would get the majority of my payments within 90 days.
Okay.
Most consulting firms can't claim that. But that being said, it's still a delay. So hiring a full-time pharmacist, incurring a $130,000 salary, uh, and then waiting 90 days for the payments to start rolling in after I hire them, that's been one of my biggest obstacles.
Okay. So right,
And go ahead.
sorry. No, you carry on, please. I
Oh
was
no,
trying.
no, it's just been hard to manage. Like I can only grow in phases. I have to. Well, I can afford this growth right here. Okay, let's do that. And then if anything comes along, like I have to say, oh, sorry, not quite yet. I don't have the money. In fact, I also need a better line of credit. Like I had to, maximize lines of credit that are not really conducive to what my needs are as the growth happens. So as a result, I've been talking to investors and other opportunities to really help this meet its need, its potential more than anything.
Yeah.
And because I can't overhaul the industry just staying in my home state of Utah the whole
Yeah,
time.
of course. And let's hope this podcast can do some help because I love the passion that you have for this, and certainly something that we can help send out to people. Take out
Yeah,
some bite-sized segments, take some videos out, and I'd love to support that really. So right now, how much of the work still runs through you personally versus the team then?
good question. So a couple of months ago, I finished training our newest pharmacist at the time, and I was like, okay, now I can focus on cleaning up my books,
Yeah.
finances, and moving forward and finding out the next phase. And then one of those phases that I was exploring was a dream opportunity for me. I had an opportunity where there was a very large medical group in all 50 states doing medical director services in nursing homes all across the country. And they were interested in merging, like absorbing my company so that they could provide consultant pharmacists across the country. And that was like my dream come true. Unfortunately, we weren't able to make it happen. Uh, a lot of things were just not where I felt it needed to be. In addition to other concerns, I had other opportunities coming up. Talking to investment firms that seemed more enticing, um, and so when that happened, it fell through. And then I told them, "Hey, I have a pharmacist that could help you out with that." So I lost an employee, and now I'm training a new one. So
Okay.
now, as a result, I'm kind of back on the front lines training again, but once that fixes, like I will have very little frontline work, and it's very much just maintaining those relationships, and kind of now that I've been back on the front lines, I'm seeing opportunities that I could be doing to train my pharmacists and kind of raise the level and our of our services even higher,
Yeah.
um, and more training opportunities. So to answer your question, in the coming near months, I will have very little frontline work, but a lot of bigger picture opportunities
Okay.
finally
Awesome.
happening after 8
But
years.
yeah, strategy to grow it. And
Yeah.
you mentioned before that you want to automate the repetitive data work. If one recurring task disappeared tomorrow, which one would buy you back the most time, really?
Ooh, probably, um, probably doing I mean, payroll isn't a huge burden, but it is like, I always have to drop everything and get it done. Um, so automation would be a huge component because right now, like we're doing a lot of really cool stuff, but in order to do them, we have to use Google spreadsheets.
Yeah.
We built our own platform to offer our behavioral health services. We have a different platform where we log our recommendations. We have to log into each individual nursing facility's EHR. We have a different platform for each service we provide, and it's creating this web of entanglement that's hard to manage. And so to answer your question, I think once we are able to centralize a lot of our services in one platform or things like that,
Yeah.
that's our biggest issue. As well as for me, payroll and uh, managing my finances through QuickBooks and whatnot. So if I was able to sit down and focus away from that stuff on the actual improvement of the services, that would be a huge. I hope that answers your question.
Yeah, it does. It does. It was quite a tough question to answer,
Yeah.
but it's given me an idea of all the things that are potentially taking up your time. And I have one question for you, and I've been thinking about this. And what's the best question? And I think I have nailed it ish. So if the model, it's a kind of two-headed question, just a heads up. So if the model and the IPA both work, what changes for the patient in the nursing home who never hears your name? Okay, that's number one. And then aligned with that, what does the collaborative pharmacy consulting look like, and what does the profession look like? So there's a lot
Okay.
going
So
there. Patient outcomes, but what does the role look like, and what does your firm look like if
yeah.
success
So
if that happens?
okay. I
When?
like that. I like that. As I mentioned earlier, 66% of medication-related adverse events are preventable. So I want that number
Yeah,
dramatically reduced. If we're doing actual clinical services and identifying and being more proactive about these issues that are potentially going to send them to the hospital with an adverse event, I want that cut down to like less than 10%. Like
cool.
there's no excuse
Yeah,
for us after 40 years to have it that high. Um, and that also goes to show that our healthcare system is too drug centric. Um, there's a lot of overprescribing in nursing homes for a lot of different reasons, and we would help identify those and get rid of those if we're doing our job right. So that's the outcomes component. I think hospital rates would go down because the number of preventable adverse events would significantly drop. So um, I think that's aspect number one.
yeah, that's aspect number
Uh,
one. That's a great answer.
and as far as what was the other one? It was
It was,
um,
what does the actual profession look like, and
okay,
then what does the business look like?
yeah. Um, if I have my way, after a few years of building this out and scaling it with the right team and the right investors and whatnot, then we would have a potential where medical teams would be want to start providing their consultant pharmacists instead of the pharmacies, and the facilities would start changing their perspective on, oh well, I get a better service when my medical provider is providing it. Let's start having that be the standard of practice, um, and to expand it because you know eventually the baby boomer generation is not going to be with us anymore, and so nursing home services are going to kind of drop off after that. So I think consultant pharmacists need to start having a more broad view of how they approach healthcare. So it's not just so centered on just nursing facilities. It's providing services in nursing, in primary care services, as well as psychiatric services. And there's a lot doing psych services already. But to answer your question, I think we just need to be embedded as part, like a necessary and needed part of the healthcare continuum to clean up a lot of the drug issues that arise in healthcare already and fix them before they even get to the pharmacy to be dispensed. Like fix it before it ever gets there.
And we spoke about AI, and this is a problem that AI won't solve, but AI can certainly help you. So it's about getting in there and getting this across before potentially people over rely on AI, I think.
Yeah, yeah. AI is a huge component here. We need to be able to show that we are clinically needed to meet that need without, being a double checker of a product. And one more component here that I forgot to mention is pharmacogenetics. The ability to identify that based on your genetic code, here's the best drug to select for you to fix this physiological problem. Right now, if you walk to a pharmacy, they give you you have to tell them your drug allergies, right? I would like, I would love to see at some point that these pharmacies carry like just a basic genetic insight
Yeah.
of what your genetic mutations are, so they would know, don't, avoid this drug, avoid that drug, but let's use this one instead. So whenever whenever the physician prescribes something, they come in and they see, oh, that conflicts with their genetic code, not just their allergies we have on file. So let's have it. We'll call the physician and have it switched to this.
And that's the future right
Yeah,
there.
yeah.
So Dr. Darren, this has been awesome. I've really, really enjoyed today's conversation, and I'm fascinated by what you're trying to achieve. And I can't wait to watch as you grow and hear the story unfold.
Thank you. I really appreciate that. It was great to be here. I really appreciate it.
Well, awesome. Well, hopefully we can do this again sometime. Thank you very much for
Agreed.
joining me, Dr. Darren.
Yeah, anytime.
Cheers.
We'll
Thank
see you
you.
later.
Bye-bye.